Hello, everybody, and welcome to another episode of the Smart Human Podcast. Today, I have the pleasure of talking with Dr. Maria Adi Benito, who is an integrative endocrinologist and director of Princeton Integrative Endocrinology. Today, we talk about bone health, diabetes and diabetes medications, thyroid health and Hashimoto's, safe and effective supplements, PCOS, diet and lifestyle tips, and so much more. So stay tuned. Hello, everybody, and welcome to another episode of the Smart Human Podcast. Today, I have the pleasure of chatting with friend and colleague, Dr. Maria Adi Benito, who is an integrative adult endocrinologist and the director of Princeton Integrative Endocrinology here in Princeton, New Jersey. She joined the faculty of the Fellowship for Andrew Weil Center for Integrative Medicine in 2012. She developed and authored the first course on integrative endocrinology for this program, where she also trained. And she's a published author, lecturer, certified meditation teacher, and studied deeply into herbal medicine. The full bio of Dr. Adi Benito will be on our episode page. But thank you so much, Dr. Benito Adi, for joining me today and sharing your wisdom on all things integrative endocrinology, which we'll get into. But thank you so much for being here.
Thank you for having me. Pleasure.
So you endocrinology is a really interesting field separate from integrative medicine. I think maybe what we'll do is just, if you don't mind sharing what endocrinology is, and then we'll kind of talk about integrative approaches to endocrinology.
Yeah, so endocrinology is a study of hormones, glands and hormones. So hormones are these chemicals that our body makes in different parts of the body, in glands, and then they travel throughout the body and they regulate pretty much every single part of what we do. So whether it's breathing, whether it's your heart rate, whether it's how often you poop, or when your cycles come, or, getting pregnant. So they have a lot of effects in the body, and they are in charge of what we call homeostasis, which means that we maintain equilibrium with our environment. So if there's a stressor, we know how to respond to that. If something, we're exposed to an infection, our body has a way to get back into balance. That's what hormones really do.
Okay, great. And they're basically signalers, messengers, but they've been with us for millions of years, and they're pretty important to the human body. Yeah. And what are some of the sort of the endocrine glands that people might not associate the gland specifically with the disease they were diagnosed with?
Yeah, so the pituitary gland is our master gland. It's in the middle of the brain, so somewhere in the middle. And that is really the regulator of all the other glands in the body, or most of the other glands. So the thyroid gland in our neck, the adrenals on top of the kidneys, of course, for women, the ovaries, for men, their testicles, and then the pancreas. Pancreas is partly a gland. So those are, the main ones in our body. The gut is a hormone tissue. It's not exactly a gland, but it makes hormones. The fat cells, they make hormones as well, right? So there are other things that we've never thought of being part of the endocrine or part of this hormone milieu, but are.
Yeah. So, so what really, this is such a fascinating topic, endocrinology, and it's really taken on so many different, since, development of the original field, it's taken on so many different, aspects of human health. Now we talk about aging, we talk about lifestyle, we talk, all of it has to do with a lot of our physiology, whether we're diabetic and our insulin levels change and glucose, resistance, or insulin resistance. I'm curious to know, since you became an endocrinology fellow and deep dive into this field, what led you into this field, which is so intricate?
I think that's part of it. I think I was really intrigued by how our hormones regulate what we do and how we function. And it just really appealed to me. I was also perhaps in a part of me being a physician and seeing so many illnesses in the hospital. There was something that I knew that I could do something about, that I could help people feel better. And that was also, important, I think, at the time when I chose the field.
Yeah, no, it's wonderful. And so you've been practicing now for a lot of years. What led you, or what was your interest in moving into the integrative medicine world?
Yeah, that was, I really wanted to know more about nutrition. I was in my fellowship doing endocrinology, and I said, really need to know how to help people, not just how to manage disease, but how we can help them prevent disease. And at that point, I reached out to different departments at University of Pennsylvania, the nursing school. Everybody said, oh, this is too basic for you. This is not. And I kept looking at both books. And then the supplement industry really exploded. And patients will come and ask, well, what about CoQ10? And I said, well, what about it? I don't know what to tell you about it. So I wanted to learn more about it as well. And I was researching boron for one of my patients with low bone density. And I stumbled upon the University of Maryland, who offers a program in integrative medicine. Reach out to them. They say, no, we're actually just research-based, but go and talk to Victoria Mazes, who you know well. She was, until recently, the executive director of the Andrew Weil Center. And, the rest, as I say, is history. I, got into the program. I loved it. I learned tons. Went on to study herbal medicine from there. And that was, really the love of my life. Studied herbal medicine. As much as medicine has been the love of my life, herbal medicine was probably my second love, or maybe my first one. So it's been a really interesting and cool journey, I would say.
And you grew up in Spain, correct?
Mm-hmm. Yeah.
So did the love of herbal medicine actually stem from a childhood exposure, or where would you say if there was a connection? Was this from your childhood?
It might have been. Definitely there's a lot of folk, herbal remedies. Your tummy aches, take a bit of fennel tea or a bit of chamomile tea. You're nervous for exams, take some linden tea. There was a lot of that growing up, and it was just part of what we did, right? So yeah. For sure.
Yeah, that's great, because it's informed you into your decision making, which I think, if you can look back, it's kind of interesting to see that line of activity. Okay, let's get back into the integrative medicine component. So that is the piece that, you're saying, which we all, colleagues say was missing in our formal medicine training. And you were most interested in at the beginning in nutrition. How do you think that now clinically you've been practicing integrative endocrinology for a lot of years now? What other aspects have you pulled in that you feel out of, sort of the integrative approach that you feel has been maybe most effective for your patients? And what do you focus on? And what has been your response to, with patients?
So something I learned from David Winston, who I studied herbal medicine with. He will have all his clients or patients fill a 3-day food diary. So everybody who came to see him had to write 3 days of food diary. I still have that, ask my patients to do that when they come to see me. And I think it's really important and helps me get a sense of this person iodine deficient, and their thyroid levels might be affected by that. Is this person maybe eating a little bit many more carbohydrates, plain carbohydrates they should be eating if they have a bit of insulin resistance? Is this person maybe not eating enough and their metabolism is being shut down? So to this day, I still have patients fill those 3 days before they come to see me. So that's been really, I think, a huge part of what I do. And I think a lot of the times, if you can help somebody eat better, I think they'll feel better. That's, I think, is a big one, right? The basics, we forget the basics, but they're not to be forgotten.
Yeah, and it's interesting because you start with food, because a lot of people start with food, a lot of practitioners, because that's the most obvious, tangible. We got to eat. I emphasize a lot of water in the work I do, and people think a lot about food, but they don't always think about the quality of their water, and that's kind of taken for granted a lot. But how has, in terms of diet, what have you found to be the most, I don't want to ever corner people into a specific diet, as I'm sure you don't either. And as we know, sugars change with the variety of people's, diet doesn't always correlate in terms of, insulin release and glucose levels. But what have you found to be the most, I guess, general recommendations for diet that sort of kind of roll out every time you see new patients?
If you fill your plate at least with half vegetables, I think that's a great start, right? Half vegetables, just half of your plate, at least half. If you want to do 3/4, that's fantastic. But at least half. I think that will make, and variety, right? and for many different reasons. As you know, vegetables of different colors have different polyphenols, so these plant pigments that help us with, lower inflammation. Because you have all this variety, you're also selecting a more diverse gut flora, gut bacteria, which then leads to decreased inflammation in the gut, but also decreased inflammation in the entire body. So there's something to be said about having vegetables and a variety of vegetables. There's this researcher who writes that we should aim for 50 different kinds of vegetables per week, pretty different. And you can think of spices and herbs into those 50.
I was going to say, I don't think most supermarkets have even 50 varieties.
Oh, yes, so they do. Oh, yes, they do.
Yeah?
Oh, yes,
okay.
they do.
I better go back.
You should do that with your kids. It's really fun to do. I used to do it with my kid. It's really fun. But, this researcher will say if you have a red bell pepper and a green and an orange and a yellow and a purple, they count as 5, right? Not just one, but all the different colors. So it just makes you go for different colors instead of just getting for one. I think vegetables are big, or some fruits. If you want to add berries to the mix, I think it's okay.
Do you emphasize like Mediterranean diet? Do you talk about the science behind sort of the anti-inflammatory effects? Do you worry about organic versus not organic? Yes. I'm just curious about your thoughts on that.
Yeah. So yes, Mediterranean, I think it's, I probably emphasize fiber in diets. And one way to get to that is with Mediterranean diets. Some people, will have an inability to tolerate beans or legumes. So Mediterranean is going to be a little hard for them, but they can be a modified Mediterranean. They can be a paleo diet, which if you put fiber into it, is fine as well. Or the Paleolithic way of eating. I do tell people, like you said, not to marry a diet, just eat cleanly without having to marry a diet. I think that organic is important. Not people used to say, oh, you eat organic because you get, more minerals. That's actually not true. You probably don't get really more minerals, but what you're not getting is any of the pesticides or all these other chemicals that we now know have an impact on our endocrine system. So that to me, I think is really big. And I think times when we really want to make people be very conscious of organic is when they're pregnant or when they have kids that they're little kids that are growing, or when the children are going through puberty. Because those are times when our development is really, those hormones are really raging right in puberty. That's when those endocrine disrupting chemicals, those chemicals that have mimicry with the endocrine system, can really affect our health. So there are times when I think it's more important than others. And there are, of course, ways, and I know that you've written about this as well. You can, have the environmental working group help you in finding those foods that have, more pesticides and try to avoid those and make those your priority for organic versus the one that don't tend to have as many pesticides. And you can perhaps, use less of organic in those.
Right. Dirty Dozen, Clean 15.
Correct.
Some of the audience members have heard, and we had Ken Cook on not too long ago. And really that is helpful because it goes to this idea where they test vegetables and produce nationally once a year. And these are non-organic versions. This is for, which is helpful when you don't have access to organic fruits and vegetables. Although I will say frozen USDA organic fruits and vegetables are in every big box store now nationally. And I really push people towards that, not only for cost and access, but because they also maintain all their nutrient value because they're often flash frozen. But the Dirty Dozen Clean 15 really points to mostly the fruits and vegetables that have a skin that gets absorbed. I mean, most of the ones that come up, badly every year in terms of higher pesticide residues on their surface are the fruits and vegetables that have a skin, not a rind, like a melon. Melons tend to be a little bit less exposed, as would, watermelon, mango, avocados, those kind of things. So, it's a great guide. And you can also rinse and wash your produce with baking soda, white vinegar, and get some of those topical, pesticides off. You mentioned fiber. Tell me a little bit about fiber and why you like people to get more fiber. What's the value of that?
I think the fiber is that the non-sexy, component that we all should really be thinking of eating more of, and we don't. It's just it's not sexy. Maybe now because it, interestingly, fiber can trigger this GLP-1 activity, and everybody's now with this GLP-1 medication for weight loss, and so fiber actually stimulates GLP-1. It stimulates satiety. It's a prebiotic. Many of the fibers that we eat are prebiotics, so they select these healthy bacteria in our gut. And fiber, depending on what fiber, because soluble, insoluble. Soluble is great to lower this lousy cholesterol, LDL cholesterol. It's great to prevent diabetes. Fiber can also, the insoluble one helps with regular bowel movements. So, can
you give us examples of both insoluble fiber and soluble fiber?
Right. So soluble fiber you're going to find in most legumes. Your flax and chia, they'll have a lot of soluble. The truth is that most foods have a combination of soluble and insoluble fiber. So almost doesn't really matter what you choose. If you're eating, nuts and seeds, you're going to have fiber. Avocados are great in fiber. They give you a lot. The statistics are that Americans consume on average 12 grams of fiber per day. As women, we need 25 grams. As men, 30. If a woman is trying to lose weight, it's probably better to do 30 grams of fiber. And what I tell my patients is that that's a full-time job. It takes a lot of effort to make sure you have that fiber.
What about going to the bathroom with all that fiber? I mean, not only eating and selecting and cooking, but then you have to spend the time in the bathroom. Yeah,
actually, interestingly enough, when I tell patients to up their fiber, I ask them to do it slowly because, if you get a lot of fiber soon, very quickly, you end up actually getting constipated. So you had to eat fiber. You had to make sure you have enough water so that you don't get that constipation, but definitely helps with regularity for sure.
And fiber really just lowers, what does it do physiologically? It helps to lower this spike of insulin release from the pancreas so that you even out.
Yes, because it helps you not absorb the sugar as much, right? So, and in partly, to be fair, it's not just the fiber. It's probably the polyphenols, those pigments in the fruits and vegetables that also actually slow down the digestion of the carbohydrates, the sugar. So what I tell people is, in my house, when we have pasta, my kid will eat his salad before his pasta. So all the polyphenols in the salad, not just the fiber, because salads don't really have a lot of fiber unless you put avocados or nuts or seeds. The polyphenols, all those plant pigments will slow the digestion of the sugar. So like you're saying, the sugars, instead of going like a huge peak, they go much slowly up. And that's not just good for insulin secretion. So your insulin levels don't get, crazy high and then plummet down. And then people feel like, jittery or like I need to eat again. But it's also good for mood. When our sugars go up and down, our mood changes. So keeping your sugars more regular, more stable, is also good for mood. So why not? And sleep, right? It helps you sleep. Things that we don't think of sometimes.
Yeah, that's so fascinating. And so, in fact, the order of your food really can benefit your physiology.
Right.
I mean, it's interesting when I think of even Mediterranean diet, which again, I'm not married to any diet, but I do love, the vast, the robust and vast array of studies that are on Mediterranean, even recently, in terms of all-cause mortality reduction, heart disease, inflammatory markers. Of course, I study a lot for rheumatology. But in Mediterranean, when I went to Italy, like big bowl of salad and then, the pasta. And so in my mind, it's like that seems like the normal way that we're served food and if we're going to a restaurant often. So I find that really interesting that there's actually almost benefit to doing that. And of course, fiber has been really well studied for colon cancer and certain cancers of the GI tract, which kind of argues that fiber and the function of fiber and kind of breaking it down and ripping it up is actually really healthy. It's like exercise for the GI tract, right? I mean, and that's why I didn't understand always these fiber gummies and fiber powders. Do you believe in those? Or do you think that if they have no other choice, a patient, perhaps it's better than nothing?
And they have so little. Look at, I mean, if you're right, and them, I mean, you've seen them, they're like, what, 2 grams of fiber? At the most 5 grams of fiber? So I think they can add up. I think it's much easier to have flax seeds, put them in a grinder, give them at your, table and grind them over your food. Put them back in the fridge because they'll get rancid if you keep them out for a whole time. But it's so easy to just, do something like that or get out, make it your own trail mix and put some nuts and seeds, skip the M&Ms, skip the raisins. And, and you have another great source of fiber. It's not that hard. And I think no matter what way of eating you prefer, you can always find ways to incorporate fiber in your diet without having to resort to a supplement.
Yeah, and I don't cook very much, but one of the things I like to do is I get a lot of ready-made things that are clean or whatever. And one of the things is they make actually already, chopped flax seeds in a resealable bag. I choose the organic when it's available. And then you push out the air, seal it, and put it back in the fridge. But you can put that on salads, has really no flavor, or leave in just a mild nutty flavor. And you can even bake chicken. With olive oil or coconut oil, and then you put that as the breading. And actually, as long as you don't go above, I think like 350 degrees, that it doesn't denature a lot of the components. And I don't cook, so
that's a great tip for somebody who doesn't cook.
For the people who want to cook, there you go. But other than that,
that's awesome.
Yeah. Well, no, I learn from patients too. I mean, I have smarty pants patients.
We all do.
And so let's get into some other, I'm so curious about your thoughts on these things. So you were talking a little bit about diabetes and the new medication. So let's just get that off the table, okay? Because I'm sure this stuff and information will change in a couple years from now. We'll be in a different conversation about these particular drugs. But right now, what are your thoughts on these drugs? Who shouldn't be on them? What are the risks? You don't have to go too detailed. And then what have you seen as the benefits? Because I know I have patients in common with you, and there's some interesting findings that you and I could both comment on. Yeah.
So, these medications, the GLP-1 receptor agonist, glucagon-like peptide receptor agonist, those are medications that were developed initially for people with type 2 diabetes. And what they do, the way I explain to my patients when they have diabetes is, if you think of diabetes, in the past we would say diabetes is insulin resistance and insulin insufficiency or deficiency, right? Just two defects in the body. Well, we know that that's not true. Diabetes is actually what we call now the octet. So there are 8 different deficits that somebody with diabetes has. If you think of metformin, for instance, which is a very common medication for diabetes, that targets 2 of those 8 defects. GLP-1s target 6. Very different, very, very different. So it's revolutionized, I think, patients who have diabetes. They're in a much better place than they were many years ago. So in the past, you would have to use different medications to treat somebody with diabetes because each one will target a different pathway. Now with this medication, you target 6. That's a big advantage. We don't have to go from medication to then insulin because this medication actually take that. They say, well, now you can use actually this medicine instead of having to put somebody on insulin. And of course, these medications prevent heart attacks and strokes. These medications don't make people gain weight. If anything, actually help them lose weight. So they're definitely very important medicines, I think, to use when somebody meets criteria for them and somebody can tolerate them. So to your point with side effects, because this GLP-1 is a stomach peptide, it slows down digestion. So somebody who already has a slow motility probably will not do well in this medicine, might not be a good candidate for these medicines, right? Somebody what we call gastroparesis, when the stomach doesn't really empty. That medicine is going to be terrible for this patient.
Yeah.
So because they slow down the stomach emptying into the small intestine, they tend to cause nausea. Some of them will cause diarrhea. The majority actually cause constipation. I've been, very cautious in how I guide my patients when they start these medications. So they have to eat differently. I make sure that they understand it's not a question of eating less. I mean, if somebody's overeating, sure, of course, eat less. But for people who eat normally, it's actually a question of eating maybe smaller meals more times a day so that they don't get too full to prevent that nausea. So there are things you can do to try to minimize the side effects. But I think for people with diabetes, they are really good medicines. I think where the world has gone crazy is in the area of weight loss. And I do think that they're very important medicines also for weight loss. I definitely use them. But I think that, obesity is a disease, right? Being a couple of pounds overweight is not a disease. That is aesthetics. And that is what I think we've gone a little bit overboard. And so I want to make that very clear that I think that, except for surgery, nothing has led to the amount of weight loss these medications can achieve.
But they're the same drug, but used for two different indications,
That's
correct?
That's
so these
exactly
are basically
right.
just renamed drugs that were used for diabetes initially, and then now, or maybe at the same time, but it was for a unique population of morbidly obese. Now, I just did a survey because I do surveys sometimes, just to kind of see where the market's going is my own way of being stealth about what's going on for pharmaceutical companies. I did a survey and it was clear that they were rolling this out for sleep apnea. Everything about these drugs was now pointing to an FDA approval for sleep apnea, which I found really interesting, but they're making this connection, weight loss, sleep apnea reduction, which, look, I think that's kind of interesting. We all want drugs covered, by the way. I mean, it's a hassle to pay cash, right? Who has the money to pay cash? Especially these are very expensive right now because they're hard to find. But anyway, it's just kind of interesting how they're evolving. And I think there's statistics like 1 in 8 people are on these drugs now or something absurd.
I did not know that, but that's incredible. Yeah.
And people are still going on to, and again, you are very strategic about how you put patients on. You understand sort of who really needs to be on. And also you're teaching them very strategic health information regarding their diet. I'm concerned about the people who don't know much about nutrition, haven't been eating well, haven't really tried the first round of health and lifestyle changes, go into these drugs and then perhaps eat only kind of junky, low nutritionally, low nutrition foods. And I think that's where we're going to have a problem down the line.
Yeah, I agree.
You agree?
100%. Yeah.
In terms of, so we talked about side effects, we talked about who needs to be or who could be on them. What are some of the surprising things that you've noticed? I'm just curious.
Well, one perhaps not as good is I've actually seen a few patients with psoriasis getting worse with these medications.
Oh, interesting.
And that, and I cannot say that that's what it was. Definitely, one of them has a side effect of eczema getting worse. So you sort of would make, you're thinking you're changing motility in the gut. You're probably changing gut microbiome. So it probably leads to something inflammatory, perhaps, that was on the surface, just, brewing, just sort of manifest. The one that I think is the biggest one is the inflammation piece. People definitely say they're not inflamed. They don't feel inflamed. Their joints don't ache. They feel better. They feel better, not just they just feel better. And that's actually been quite interesting to see in some of my patients. Some people say that IBS gets better when they're on these medications. So they prefer one versus the other because one targets the IBS, the other one doesn't target the IBS. They notice these things. And so we're learning also from our own patients and what,
And it is interesting because adipocytes, which are fat cells, when they shrink, they really just mostly shrink. They don't technically go away.
Correct.
You can confirm that. They're inflammatory. So there's a logic to this that when you shrink your fat cells, that you would have less inflammatory markers, less communication between cells that's inflammatory. So it kind of seems to make sense in some of these autoimmune diseases that I've seen. I'm starting anecdotally, of course. This is all anecdotal. Seems to get better. And that's kind of like mimicking anthropology and having less hunger or less food and stacking of calories during the day. Yeah. It makes sense, right? Yeah. We're giving our body a chance to rest and to digest and to physiologically function before a whole new onslaught of calories comes in and we got to manage that again. Would you agree?
Yeah, I do. I mean, one of the... I think I almost put every single one of my patients on this fasting-mimicking diet by Dr. Longo. And just because of that, it's a reset in a way. It's 5 days of a vegan diet, very low calorie, very low protein, just for 5 days, once a month, consecutive 5 days, once a month for 3 months. And after that, people will do their every 3 months or twice a year. He's shown that actually people lose weight, their sugars improve no matter what they start. Everybody improves. They improve their energy. And it's because he's actually targeting mitochondria. He's actually helping people regenerate mitochondria, which is the energy part of the cell. Amazing data. I think that to me, is a much healthier way to, reset your metabolism than a medication. Again, some people need the medication. And again, that's important that we have them. But I just love his work. I think it's...
And this is who? Dr. Longo?
Longo, Walter with a V, Walter Longo. He is Italian, has a really cool story. I mean, you had to... He's the author of the Longevity Diet. Is a researcher in California as well as in Italy, where he's from. And his goal really was about this anti-aging. That was his whole research was about aging and anti-aging, and stumbled upon, how people really feel better when they're in these water fasts, but how hard that is to do. So he's mimicking water fasting for 5 days when he puts people on this. And it's a very specific amount of carbohydrates, proteins, and fats per day. And they change throughout the 5 days of the diet, but so that it mimics this water fast, and it really works well for metabolism. So I have some patients who've done amazing on this protocol as well.
So that's interesting, and they can go online to probably find that work and that program. Because I think I have a patient. Prolon, is that the same
Prolon
thing?
is the company that provided the food for the studies. Of course, it's packaged food, not horrible, ingredients, but correct.
And people can do it on their own. I mean, I don't want to promote a program unless, you've had success with it. But
if they have diabetes, I think they do ask them to see a physician so that they can be guided, because especially if they take insulin, it's a very low calorie. They probably needs a reduction in their medication dose.
Yeah. And when your body changes, you have to adjust a lot. That's the same thing as if you're losing, 10 pounds versus say 30 pounds, you've really lost such an enormous amount of your body. You have to kind of reset all your medications, really, if you think about it, because you're treating a different human. So that's really interesting. So let's get into some other areas. Thank you for sharing all of that, because I think it's just so it's so valuable. And as we move through all the studies and we're really going to learn more. But let's go back to some old school stuff. All right. Let's talk about thyroid gland. I'm a particular fan of the thyroid gland supporting it and understanding it and trying to figure out why we have this epidemic of thyroid conditions. I see young women mostly on thyroid medicines. And I wanted to get your take on that and why we have this epidemic, and is there a nutritional component? So just let me know what your thoughts are on thyroid. Hashimoto's, that kind of thing.
Yeah. So in the, maybe we'll take a step back, right? And so in the Western world, the most likely cause of thyroid dysfunction is Hashimoto's. And Hashimoto's leads to hypothyroidism. Hashimoto's is an autoimmune condition. So again, a condition where the body is going to produce these antibodies, these chemicals that target usually foreign substances. But in the case of Hashimoto's, they are attacking the thyroid, our own thyroid. And over time, what they do is they destroy normal thyroid cells that make thyroid hormone, and it replace them with inflammatory cells in the thyroid. So the thyroid has a fewer thyroid making cells and more inflammatory cells. So of course, over time, that leads to somebody becoming hypothyroid or underactive thyroid function. So we've known, and in the Western world, that's the most likely cause. In the whole world, the most likely cause is iodine deficiency. And of course, that was in the past, very segregated to certain parts of Africa or maybe in China, but it's actually becoming more prevalent in our country as well as in Europe. And there are studies showing that adolescent girls actually are iodine deficient, which is a concern because iodine is important for the baby that is in utero to develop a brain. Without iodine, the brain doesn't develop. So if these girls don't have iodine and they at some point, get to the point that they have babies and they don't have enough iodine, there could be definitely more mental retardation, perhaps more ADHD has been also linked to low iodine in pregnant women. So that, now it's like, okay, what are we seeing now? We're seeing Hashimoto's, which is the most common condition to lead to hypothyroidism, underactive thyroid, or are we seeing iodine deficiency? And not to complicate things more, but of course they are complicated, you now put in the mix of this all these endocrine disrupting chemicals, all these chemicals that affect the endocrine gland. And of course, some of them actually compete with iodine to get into your gland. So if you don't have enough iodine, they're going to be more likely to come into the thyroid gland. So now you're not only exposed to them, but you're actually open the door to those chemicals. So I think it's a combination. Of course, some of these chemicals change your immune system. They target the cells that then lead to Hashimoto's. So Hashimoto's is an autoimmune condition, and as such, it's partly genetic, so that we cannot escape, but it's partly environmental. And on the environmental things, we've known about viruses and maybe actually too much iodine leading to Hashimoto's. But we also know that these environmental disruptors, these endocrine disrupting chemicals, are very likely a part of what we're seeing. So it's a complicated sort of soil, but suffice to say that I think it's important to try to avoid chemicals as best we can. Whether it's filtering your water, whether it's to take out the plastic of, salmon you just bought and just putting it into a glass container, whether to, buy cans that don't have this BP anything, BPA, BPF, BPS, BP, whatever. But at the same time, make sure you have enough iodine in your diet, not as a supplement, as food, How about a little bit of iodized salt? Just half a teaspoon a day. That's all you need. You don't like salt? Okay, get dulse flakes and get a half a teaspoon every day. Same amount of iodine.
That's seaweed.
Yep, that's seaweed. But it's one of the seaweeds that doesn't give you a lot of iodine. Some seaweeds have tons of iodine.
Dolce and nori, I think, are the two that are probably lowest. Yep. They have the reasonable amounts.
Yes, you can have a sheet of nori every day, or one of those little packets of nori, snacks. And that you have your, enough iodine if you prefer not to do, seafood, or you cannot do seafood. No, it's a fascinating topic, and you hit exactly upon what I tell patients is that it's a combination of not only a nutritional deficiency, because look, it used to be, there was a public health measure in the United States. They used to add it to brominated to bread to help bread rise. And the government, U.S. government actually, they got this kind of right, where they, noticed that there was higher rates of goiter and deficiency around the world. And so they started but no one eats bread anymore. A lot of people don't eat bread. And then they had it in table salt, like Morton's and what have you. And then no one has table salt because that's just sodium. That's right.
People have Himalayan kosher and unprocessed salt, Celtic salt, which has no processing, and it's got magnesium, potassium, it's all of it.
But not iodine.
So, but no iodine, right? And it's hard to find that kind of salt with iodine added.
Yes.
For some reason, I'm not sure if that's a manufacturing, problem or issue. But you have this combination of not enough, then no one's testing it, right? Doctors typically do not test iodine. I tested in the urine.
It's just really hard to test. Yeah. If you think of the literature, they'll say you need about 10 tests to get to somebody's average. And it's because iodine is not a storage. So when you measure iodine, you're measuring what you had the day before. So if you ate mussels, it's going to be super high. And if you had nothing with iodine, it's going to be super low. So what are you really, when
you're testing, if you test, I test urine.
You do, yes.
Spot urine.
But again, it's not perfect.
It's not perfect.
It's not. Again, you need to test about 10 before you get. So I think it's much easier to, what I do, and that's part of the reason why I ask patients to bring me their food diary, I get a sense of what they're eating. If somebody's vegan and they don't have any seafood, any seaweed, very unlikely they're going to have iodine. Now, did you get iodine from the soil? But, the USDA does not mandate that iodine is labeled in foods. So you have no idea what you're getting, from the soil, if any. So
and OB-GYNs, gynecologists and OB-GYNs don't test it either, especially when it's most important when you're having a new, a woman going into a pregnancy where it's so important for brain development of the fetus.
Yeah.
So there's that disconnect between what we know nutritionally and what we're doing clinically.
And I don't fault them for not testing. Yeah. I would say that as long as they can recommend that a woman takes a multiple vitamin with iodine in it, and that the iodine is potassium iodine, which is much more reliable as a source of iodine than, let's say, kelp. That I think and actually there has been a survey in the United States. There was a survey in, forget now the year, but it's been like about 10 years apart. And initially this survey was like very few physicians will recommend women to have, and very few of the prenatal vitamins actually had iodine in them, where now most of the prenatal vitamins do have iodine in a sufficient amount for women, who need it, and babies who need it.
I recommend a multi, a high quality multi with no junk, coloring, preservatives. But among the criteria that I call out, which not many people, I guess, think about, is having enough iodine in your multivitamin. 150 micrograms is what I recommend of sodium iodide, which is on the label. And that way you're getting a controlled amount, not a liquid. I remember hearing a lecture from you about the liquids that are so variable. But having it in sort of a capsule form.
Potassium iodine is what you really want to make sure that you have in that. And like you said, 150 for an adult who's not pregnant is a good is a good dose. It's a good
Less
amount.
for more for a pregnant female?
Yeah, 220 to 250,
Okay.
290. Yeah,
Good to know.
a bit more. But if somebody's already eating, some sort of iodine and then takes a prenatal or even a regular vitamin with 150, it probably is enough. Somebody who doesn't have any iodine in their diet, maybe you want to get one with a little bit of a higher amount than the 150.
Right.
Yeah.
Yeah, this is so useful. And just as another component, there's a lot of environmental chemicals that you mentioned that compete. And people might have heard the forever chemicals, PFAS, perfluorinated.
Yeah.
Well, that fluorine or brominated flame retardants, the fluorine, bromine, chloride, they're on the same vertical as as iodine on the periodic table for elementary school. So we understand that those are how they kind of jump in. So if you can get those environmental chemicals away a little bit, they won't compete for those spots in the thyroid gland. What about thyroid cancer? Thyroid cancer has really had an uptick over the last couple of decades. What do you attribute that to, and what do you tell patients about prevention and management?
Yeah, that's a little bit harder too, because a lot of the question has always been, or has been for us, are we seeing more because we're detecting more and we're detecting it early, and some people are being really aggressive? Are we really seeing more? Definitely some of these chemicals, including the PFAS that you just mentioned, they do actually have a link with, in some studies, with thyroid cancer. So even when we cannot put our finger and say, yeah, this is what it is, we're definitely telling people to be cautious, because there is, some noise, if you wish, right? So there's something that we're starting to see that makes us a little bit concerned that there could be, thyroid cancer. So, can you prevent thyroid cancer by avoiding these chemicals? And we hope that the answer is yes. The problem with these chemicals, as you know, is that they go through generations. So if your grandmother was exposed to them, now you actually are the one who is suffering the consequences of it. And I think that really is why I think it's so important that we, as a society, actually, or potential grandparents one day, that we do the best we can to try to prevent them and avoid them.
Yeah, generational exposures. Yeah, and they transgenerational, even with the genetic changes that go on from a mother or grandmother's exposure.
Yeah.
And look, I say today is the first day of the rest of your life. Let's not look back. Let's look forward. But you're absolutely right. Anything we can do is going to be helpful. The thyroid cancer has been a particular interest of mine because it has increased over time. As you said, that there's a lot of different reasons why that might be, detection, that kind of thing. But again, back to this idea of prevention is always a good place to start. So let me ask you some other things. When it comes to things like bone health, which is also an endocrine, moderated, illness. You could call it an illness, but I look at it as just normal aging, right? Osteopenia, osteoporosis. We're all outliving our tissues. Okay, let's put it that way. We're living a lot longer than we were meant to anthropologically, and so everything's crapping out. Okay, I'm 51. I feel it. All right, but in terms of bone strength, and what would you tell, women who are starting to get their first bone density? They probably didn't have any reason to get it until they hit an age group. Or they may be in medicine like prednisone, certain medications, certain diseases like rheumatoid contribute to bone loss. So there's some reasons why people might get a bone density early. But what are your, recommendations for keeping bones strong? And then what are your thoughts on some of the non-pharmacologic and pharmacologic therapies in general?
Well, a big one, right? So I think ideally what we want to all be doing is to get our bones as strong as we can before we hit age 30, which is when we get our peak bone density. So up to age 30, we build bone. After age 30, we start to lose it. As women, when we get to menopause, because we lose estrogen, unless we go on hormone replacement therapy, we lose bone usually for the first 5 to 10 years. So you want to build it up. How do you build it up? Or how do you maintain it if you didn't build it up when you were younger? So calcium is definitely part of bone. You want to make sure your diet is rich in calcium. And I think we're moving away from using calcium supplements Of course, if somebody cannot get to how much calcium they need, then you add a supplement. But supplements should be a supplement, not the only way you take calcium. So whether you do dairy if you tolerate it, whether you do dark and leafy vegetables, sardines or salmon with bones, almonds, broccoli, all of them are going to give you calcium. Also, if you don't have a super high animal diet, so animal protein-based diet, you're not going to pee a lot of calcium out. You're going to hold it. So that's good. Dark and leafy veggies, in addition to giving you calcium, they're going to give you magnesium and boron, and both are really good for bones as well. So you can use those. There's a study using prunes in women who, hit menopause and how it prevents bone loss. Prunes have boron. Again, you don't have to eat prunes. The study was like between 8 and 12 prunes, I think, per day, which is like crazy amount of prunes. Find other ways to get your boron, whether it is through, nuts or seeds or, again, dark leafy veggies. So all those are important. Things that we probably have a harder time to get through diet is vitamin D and vitamin K. And those are important for bone density. This vitamin D has been really controversial, and people say, well, there was a study where they said that vitamin D didn't really help prevent fractures or bone density. And I said, well, that's because you're thinking of vitamin D in a very narrow context of osteoporosis. So when we see a bone density and the bone density labels osteoporosis, it's like a stamp has been put on that. That's what it is. Well, there are conditions such as vitamin D deficiency, which we call osteomalacia, that look exactly the same as osteoporosis and bone density, exactly the same. But the treatment is not to give you medication, it's actually to give you vitamin D or calcium. So I think it's good to take a step back and try to get a sense of are we treating osteoporosis? Are we treating osteomalacia? What are we really treating when we're treating these bone densities that are low? Omega-3 fatty acids, DHA in particular, has an impact on bone density. So, I definitely want to make sure that somebody is going to be finding a source of omega-3s in their diet, whether it's walnuts or salmon or sardines or mackerel, maybe eggs that are enriched with omega-3s. So all those, I think, and of course, we're talking about the gut before. So the gut is also very important. We have studies, not in humans, but in mice, using these fructooligosaccharides, which is a type of prebiotic fiber. You find in dandelion, you find in masculine garlic and onions. Those actually seem to modulate the gut in a way that they actually protect bones. We have data on probiotics in women to prevent bone loss. So, the gut is important. Having orange colored foods, those carotenoids are really good for bones, right? Not a supplement, but as foods. So all those, I think it's what I tell people to do to try to maintain the bones, and that's with diet. Then you want to talk about exercise, and you want to do something that is weight bearing to help, move your muscles, but also get your bones to be, strong or as strong as you can.
Yeah, no, those are great ideas. And for the weight bearing exercises, the reason they're of value is because bone is a living tissue and and it works off of forces, which is, kind of why, when we get osteoarthritis, it's the nubbins on our little fingers. It's because bone hits bone and it's growing, but we want that bone growth in our hips and in our spine. So for the same reason we don't want it in our hands and extra places for arthritis, we do want it for bone strength. So that's kind of where the weight bearing is that it does grow when there's pressures on it. But I think it's a great point that you make is that you can really get quite a bit of calcium and nutrient-rich substances from food, particularly even plants. And people think when they think calcium, they think it has to be dairy. But we now know that saturated fats comes with problems. And so some of those dairy, I would say it has to be high yield. What do you say? High yield dairy, maybe low fat or I don't know about low fat, but cottage cheese. Yeah,
cottage cheese, yogurt and cheese. So that I think most studies or pretty much all studies don't really think of them being, again, everybody's different. So if you have an issue with dairy, you don't do it. Milk is the one that has, the data is very mixed. You have studies that say milk is amazing, studies that say milk is horrible. Well, don't do milk because we don't know what it really does. But maybe yogurt and cheese, if you can tolerate them, I think it's a good, or cottage cheese. I think it's a good, it's a good way to, if you tolerate them. And if not, like you said, there are plenty other ways to get to calcium in our day.
Yeah, and supplementing can, kind of contribute to cardiac plaques is really what the concern was. Certainly
Correct.
men.
Yeah.
I think the study is a little bit off from women, but we know
Correct.
now that men shouldn't be on calcium supplements in general.
Yep.
And there are exceptions to that, of course. But yeah, and in terms of fracture risk, which is ultimately what we're trying to prevent, bone densities, you can confirm this. You treat lots of osteoporosis and, you're an endocrinologist. But it turns out to me that bone densities are more of a warning sign in terms of what to focus on, often more so than just boom, right to pharmaceutical treatment. And I think that's the problem, is that we use those numbers to get people right into drug, when we can use some of those numbers to really get people into weight bearing, watching your fall risk, rugs on the floor, managing blood pressure is not too highly, greatly controlled, where you fall down with high blood pressure medicine, hydration, inner ear, vision, hearing, sensory. Thoughts?
Yeah, I think that's correct. So we used to call, what we now call low bone mass, we used to call it osteopenia. And osteopenia, the name just suggests you have a disease, right? Something bad is going to happen to you. When I was training, my mentor would say to people who had this osteopenia or now low bone mass, he would say, listen, you're short, but not a midget, right? So some people are short, but not midgets. They don't have a disease. There's just a little bit of a lower bone density. But yeah, it's a chance for us to say, okay, are you somebody who has this low bone mass who's going to progress to osteoporosis, where you could actually have a fracture? Are you somebody who's not going to progress, who has no disease, who your bones are just the way they are, but will never have a fracture? And that's what we're trying to ascertain. It's like, who are you who is sitting in front of me? Do I have to worry about you? Is there something that we could actually do to prevent bone loss if you're in a path to lose bone because you have the genetics or whatever it might be, or the medication, right? And one thing that I want to also mention is that you mentioned people who have rheumatoid arthritis, people who have diabetes are also at increased risk for bone fractures. And we don't tend to think of them as people who have a high risk, but they do. So they also have to be in our mind that they need a special attention.
Yeah, no, that's a great point. In terms of, and I say this, obviously people should always talk to their doctor and really be discussing osteoporosis, osteopenia, all those treatments, because it could be medically induced. We have to think about those things. But in terms of just general statements on supplements for bone, if you're not going to have this crazy healthy diet with, 8 fruits and vegetables a day, and you're working 2 jobs and, life is busy, are there supplements that you have found to be effective in, as an outcome, not having fractures or, obviously that's anecdotal if it's personal, but more so also in bone density numbers maintaining themselves as opposed to worsening?
I think the one that I found the most beneficial is probably probiotics started early on. It's probably not just that. It's probably the combination of everything. I'm trying a few supplements that somebody will come, and there's some studies that have some data for this combination of berberine with hops is a, sort of like a hot thing now. So, one thing that I do, if the patient is willing to do this, because sometimes insurance will not cover this, is to measure bone markers. So, when the bones are remodeling, when they form and they break, or not they break, but they sort of erode a little bit, they release these chemicals into the blood or even the urine, and you can measure them, right? You can get a baseline, and then you can measure them 3 months later, once you get yourself on whatever plan you want to be on. So it's a way to know, is this plan really working for bones? Is this really going to lead to an increase in bone density? Is it going to prevent fractures? Because if it's changing your bone markers, and usually we look for a 30% change, or usually a decrease with these bone markers that are the ones that lead to the bone breakdown, then that's working. That's doing something. If you're not seeing that decrease,
for 30% difference, is that the C telopeptide, or
correct.
Do you use N telopeptide? You like C?
I like C. I think it's easier for people to do some blood tests and not a urine. I think it's a little bit more robust than the N telopeptide. Just a little bit, not a ton, a little bit.
So you're saying serum C
telopeptide,
blood.
Correct.
Okay.
That's the one that
gotcha.
I like to measure and see whether that changes or, over time after whatever protocol you decide to use for somebody. It's a nice way to do, instead of having to wait 2 years for the bone density to change and then find out that maybe you didn't, really change anything. you have something you can measure 3 months after.
And is that a spot, a moment in time, like you said, like maybe iodine would have been, or are you saying that has more of a build-up time where you can really look at this change in time?
You can definitely do a moment in time. The problem with C-telopeptides, as well as any other bone markers, is that they're quite variable. So you want to make sure that you do them first thing in the morning. You're fasting about the same time every time. People cannot be on collagen supplements at the time of doing the test because collagen is going to just show up on the blood test. So they have to be off it. I tell them to be off it for a week just to be safe. But they're not perfect either. They just give you a sense of where you are and if you're moving the needle somewhere.
Yeah. And speaking of supplements that you have to be off of, I think it's always good to give nice practical information. When we were talking about the thyroid, what are some of the supplements that you might want to think about? Because a lot of people are doing supplements, right?
Yeah.
This is a thing.
Yeah.
And we just want to, from a diagnostic perspective, there's certain supplements that interfere with really, the results so that you get false readings. So tell us about that with thyroid.
The big one is biotin. We now know that biotin, a lot of the tests we use in the lab to measure thyroid hormone are based on biotin. So if there's biotin in the blood of the person who's going for the blood test, it's going to displace the assay. It's going to displace it and read it wrong. So it's going to make somebody look like they're hyperthyroid when they're not.
Hyperthyroid.
They look hyperthyroid. It's not just thyroid. I mean, it's any immunoassay, we call them, right? So this test that we use in the lab, the commonly used tests, biotin will display. So there have been reports of people with, vitamin D, cardiac markers for heart attack. Somebody leaving the emergency room thinking they were fine when in fact they were having a heart attack, but it was negative because they were on biotin, and the biotin sort of like obscured the results. So it's good to know if you're on biotin that when you go for blood work, you hopefully hold it for about 72 hours. And if you can't, that you tell whoever's reading those blood tests that you were on biotin when those tests were done. So that at least we have a sense of, that there could be a misreading of this. So it doesn't hurt the person when they take biotin. So they are safe if they want to take biotin, but the labs can look weird and erroneous if they don't stop biotin.
Biotin is one of the B vitamins, is it not?
And it's a B vitamin. It's, super common in like hair and skin and nails because it
What about a multivitamin that has biotin?
So it depends on the amount. Usually we say that about 300 micrograms above that is when it's more concerning. I still have people stop it just in case, for whatever the reason, they don't metabolize it quickly and still in their system by the time they go to do blood tests or whatever it might be. Oh. But it's usually the amount. It's because a lot of those hair supplements or skin supplements have like tons and tons of biotin, right? Yeah.
That's great information, really is. Any other, there's some other supplements I know you've talked about in the past. And again, I don't want to focus this. I like to focus on diet, nutrition, and really things that are super anthropologic and feel real and tangible. But we're in a world where people are, like I said, busy and they're looking for support. There's some other supplements. I know that you talk about berberine a bit in diabetes, or I should say pre-diabetes, where the data is more robust. Tell us a little bit about berberine and any other supplements that you think are helpful.
So berberine is an alkaloid of plants. So it's in golden seal, Chinese coptis, bayberry, and it has actually lots of uses. Berberine changes the gut microbiome. So it's actually used in protocols when somebody has abnormal gut flora, where the gut flora has become imbalanced. And perhaps because of that, it has an effect on sugar metabolism. So there have been studies, actually something that really patients love is a study comparing berberine to metformin. Metformin is a medication for people with diabetes. It's used off-label, meaning there's no indication for it, but we use it for somebody with pre-diabetes or insulin resistance, such as polycystic ovarian syndrome. So in one study, they compare women with polycystic ovarian syndrome. They put them on berberine, they put them on metformin. And berberine and metformin were equally good for weight loss, but berberine actually helped reduce waist circumference a little bit more than metformin. So it was a win-win for berberine. I think berberine can be beneficial for people with pre-diabetes or insulin resistance. I think it's you have to always be careful of what medications you're taking. Berberine is one of the ones that could actually have interactions with medications, just by the way that it's metabolized in the body. There are supplements that are a little bit easier to, that are not as likely to have interactions. I love inositol. Inositol is a sort of, not exactly a B vitamin, but it's in the B family. It's an antioxidant. There are different forms of inositol. There's something called myo-inositol. There's something called D-chiro-inositol. Interestingly enough, the combination of the two has been used in PCOS, in polycystic ovarian syndrome, and it's actually part of the recent international guidelines. They do talk about this combination. They do say that it's not as strong as metformin, which it isn't. That is true. But it can be good for somebody who has mild symptoms of PCOS, polycystic ovarian syndrome, or somebody who's looking to do something else. Inositol, interestingly enough, is an insulin sensitizer, so it makes the body's insulin work better, but it also helps the thyroid work better. So it's a thyroid hormone sensitizer, if you wish. So, and there are studies now. I think the strongest data we have in patients with Hashimoto's is the combination of inositol and a low dose of selenium. So that combination seems to decrease thyroid hormone probably more than any other supplement that has been studied. Better than selenium by itself, better than ashwagandha, better than black cumin seed. It really is probably the most potent that we can offer somebody.
And that's the myo-inositol with the low-dose selenium, but not the other type of inositol.
Not the D-chiro, no.
Interesting. And that's been shown to be most helpful with Hashimoto's in reducing antibodies on labs,
Both.
or really how they feel?
Antibodies reduces TSH. It improves immunity overall.
That's interesting. And you can't get inositol can you get that from food? I mean, is there foods that are rich in myo-inositol?
Not to the amount that you will need for, you need, so the studies that were done use about 600 milligrams of inositol. So that's one you really need a supplement and not a food.
And that's once a day type of thing. And there's side effects to inositol? Myo-inositol?
I would say that for 600, probably not. But if somebody were to have a high dose of inositol, they get a little bit of, for some people, not everybody, some people will get a bit of discomfort in their gut, maybe a bit of bloating. Some people also may get a bit of diarrhea. But it's not common. Some people love it because it gives them more energy. Again, it's part of those B vitamins, so it can give you a bit more of that.
Interesting.
Yeah.
Boy, you are a wealth of knowledge. Oh my gosh. So I want to move from supplements, and I just, I know we're going to be ending soon. I guess I want to step away a little bit. What are, if you were to give sort of a top 3 or top 5 list of things that you could do 3, you could do 5, things that are really just the most valuable information for lifestyle that helps hormone health. I mean, I'm trying to frame this around really your specialty and what you do and what you've seen. What can you really say is, kind of the top high yield commentary to keep our hormones and our immune system through our hormones healthy?
That's tough. I'm going to say balance is important. So balance of exercise and energy. So energy meaning what you take in as food. So that imbalance of eating too little, exercising too much, or we've known for years that can affect health. Both men and women, actually, their endocrine system shut down. People who go on extreme diets, a keto diet, and you do keto for a long time, then people come and say, oh, my T3 levels are low. Sure. Yeah, they will be low. You're actually putting your body into a bit of a starvation. So your body's going to shut down a bit of their metabolism. So there are things that we can prevent just by being a little bit mindful about really keeping that balance of what we eat and how we eat, and our exercise. I think it's important to work with the light of the day and not eat at night, not to be partying crazy, on every day, or, whatever it might be. Some people need to work late, and I totally get it. That's a very different, situation. But trying to maintain a rhythm of when you go to bed and when you get up in the morning.
Yeah.
Changing that circadian rhythm, changing that affects your hormones, affects inflammation, leads to cancer. There are many negatives of changing that rhythm. So stay in tune with the light as best as possible, right? I understand that in winter it's pretty hard to do and to eat before it's, dark, but, don't be eating at 1 o'clock in the morning type thing. And then stress. Really trying to manage stress as best we can. So stress is unavoidable. We're all going to be exposed to stress, and it's going to happen, just things that we have no control over. But knowing how to deal with that stress, whether it's because we meditate, whether because we have a practice, we walk in nature, right? We find a little corner that we do something that is relaxing for us, that has meaning. I think that those are really important. Our body can only do so much. And if we really push it, we get into what we call allostatic load. So we're pushing and pushing and pushing. At some point, our body says, I'm done. You're on your own, pal. I'm out of here. So you need to take care of your body. And I think, we need to care for ourselves and care for this human frame that we have. And, for us and for our kids and grandkids.
I love it. Really, just great advice. I love the commentary on circadian rhythms and the sort of the sensitivity of our body to even light, noise, what have you. It's just so great perspective. So, are you still practicing? Where can people find you? And what are you still teaching? And what is your life like now?
Yeah, so I'm practicing. I'm not taking new patients, unfortunately. My practice.
You'd get a lot from this episode, I can assure you.
I'm really sorry, but I can't. I'm extremely, extremely booked. I am teaching as well. Just started a new teaching job, which is going to be fun. And my hope is actually that at some point I'll teach clinicians to, especially thyroid, which I think can be quite complex. And, what's a thyroid panel? Do we need to check TSH and T4 and T3? Do we need to check your free hormone and your total hormone? And how do we, all those things? I think at some point I'd like to do that. But yeah, life is full for sure.
Yeah, I'm glad to hear that. You seem happy, and I just love having you in my neighborhood. I can't even believe my luck. And so, I guess the last question: just what makes you happy?
What makes me happy? I think to have a purpose makes me happy. The purpose. I think my family makes me happy. The land, the land makes me happy. I think of I'm going to Spain this summer to visit my family, and just getting the train and being on that land, it's just it just makes me really happy. Seeing chicory, on the side of the road, it makes me super happy. Chicory is such a fun plant, right? And the root is full of this good prebiotic fibers. So yeah, nature makes me happy.
I love it. Well, listen, it has been such a pleasure having you. I could talk to you for hours. I'm sure the listeners feel the same way.
I wish I could interview you.
Oh my gosh. No, you don't want to hear from me. Everyone's sick of hearing from me. But I'll tell you, I've been waiting a long time to lock you down, and this has been wonderful. So thank you so much for sharing your wisdom, sharing your time, and I hope you enjoy your chicory and enjoy the things to come. So thank you so much, Dr. Adi Benito, for sharing everything and for being a part of the Smart Human podcast today.